Rosario Pascarella a unirsi a noi per cominciare il dibattito. Okay, abbiamo pochi minuti ma cerchiamo di sfruttarli al meglio. Ringrazierei inoltre tutti gli speaker, davvero delle presentazioni fantastiche con delle immagini veramente belle. Prego, Rosario.
Attenzione, innanzitutto ringraziare gli ospiti tutti per le relazioni veramente esaustive. La prima osservazione è sulle forme atipiche in particolare di SAH, in particolare su quella mi volevo soffermare sul lavoro pubblicato da Horst Urbach riguardo alla spinal dementia. Volevo chiedere, Horst, I would like to ask you something about your case report about the spinal dementia and the brain sagging dementia. What is your clue? And finally.
I've shown you that a lot of patients have cognitive symptoms. Some of them are so demented that they do not can perform their activities of daily living. That is the dementia. We called it spinal dementia to say, look for the spine to find the cause of the dementia. I know that many neurologists did not like this term, spinal dementia. Another term may be brain sagging dementia. The term originally proposed in 2005, behavioral variant frontotemporal brain sagging syndrome, is so difficult to understand that I want to have a short-term spinal dementia or at least brain sagging dementia. The definition of dementia, okay, there have to be reduced activities of daily living. How do you consider a SIA patient who does not live really because he is lying flat all the day? Is that is the cause why he is not doing well? That is not dementia. But you could, on the other side, say, okay, this patient is not able to do a regular task. And I do not know how many patients really would say they have brain fog. If you ask them, I mean, most patients have the orthostatic headache as complaint, but if you do some tests with them, you will see that they are not doing as good as after the repair of the CSF. So that is the summary of why I put the word spinal dementia, just to say, look for the spine in these patients.
Thanks.
Could I understand the question and was it correctly answered?
Yes, it is. Thank you. Just a question, direct question for Dr. Carton is, do you perform the opening pressure measurement in the pressurizing the examination, the myelography? Did you use the opening pressure?
So, is it on? So, for fistula patients, we always do, because the patient is in the lateral decubitus position. And the only reason I do that is really for an academic measurement, because it's not going to change the examination that I do, other than if it's very low, which is actually a minority of patients, then I will give more pressurization before I give the contrast. As long as we keep the head up, some patients will have 20, 25 mils, even 30 mils with the brain sag dementias of pressurization. Is there good evidence for pressurization that's published in the literature? No. There is really only the case report from Freiberg which actually shows it. But in our experience, when we started doing this regularly, our pickup rate of fistulas went really high.
Okay, thank you.
And we don't do it for when the patient is prone for ultra fast. You can't get a pressure measurement.
Just want to add to that, so the pressure monitoring for CSF venous fistula, so patient where we suspect something like this, we do it because that position is already there, and we're still looking for the one test that helps you really saying you that there is a fistula, because we don't find any patient probably because we were missing this one diagnostic test. So for SLAC positive leaks, we don't care about the pressure, not at all. But for CSF venous fistulas, just to get this extra information that maybe help you when you have like suspected patient with a CSF venous fistula, the opening pressure is 5, then I would be more willing to repeat the examination. When I would do like pressure monitoring, it's like 15, 16, 20, and I don't find anything, then I would consider stopping earlier.
Something also to say is, Ika and I were just talking about this, obviously Horst showed some cases. We think that this IIH decompressing through fistulas is probably far more common than we think. We just often don't have the imaging of the patient in their IIH state. So when we measure a pressure measurement and we find a fistula and the pressure measurement was 15, well, that is within the stated normal range, but it's probably not normal for the patient.
C'è una domanda dal chirurgo Chioffi davanti a lei, poi il dottor Muto.
As far as hypotension, we have seen, we have heard several therapeutic options. But as far as intracranial hypertension, which are the therapeutic options right now, at the moment?
Who want to answer to this question?
So I think there will be a topic, some will cover the endovascular stuff, but like I said, there are like, in my opinion, like 3 or 4 therapy options we have. So that when we consider conservative treatment, I include like medication, right, with Diamox and whatever. So this is, I think, the first line treatment. But depending on what the patient is doing, when he is already in vision loss, I would not start with conservative treatment, in my opinion. So then you could go in directly for lumbar puncture and just getting rid of the fluid and the pressure. I still would consider this conservative treatment because it's really, really easily done. And then all the other 3 steps would be like optic nerve root fenestration, then continuous drainage with a shunt, for example, and then that will be covered this afternoon with sinus stenting, right? And how good everything compared to each other is a big topic because there are no comparative studies. And we know that the stenting that entered service a couple of years ago, and we were really excited that we have now the one treatment. We still have not a lot of data for it, and then one publication from the biggest group in the US, like around Kyle Fagen, they just published data this year where they have like recurrent symptoms in more than 50% of the patients. So it's still really, really effective, but it's not like the golden treatment to go for. And then you have to discuss should we do like second line shunting or second stenting, third stenting. But I think because there's no comparative studies, we're still struggling. But I think the combination out of conservative treatment for, let's say, not high risk patients, it's a good option. We have some patients where we started with Diamox and they're totally fine. But we have patients, they come with 2 grams of Diamox, a lot of like adverse events, and then you have to go further. And then you should evaluate like shunting, optic nerve root fenestration and stenting, depending on how your invasive follow-up will be, but this will be covered as well in the afternoon, I think.
I think this afternoon we will talk about treatment, so let's give the microphone to Mario Muto.
Quick question to Lalani. Do we really need the renal phase?
Sorry?
We really need the renal phase evaluation?
Renal contrast, yeah? So I don't do a separate phase for this. What I do is when we have the scan, I just ask the techs, can you open up the window? It's no extra dose, so that I can recon to see the kidneys. This is only if I haven't found the fistula. And I look, if there's no contrast, it's not helpful. Because I have many fistulas, we don't see renal contrast. But if you see it, then I'm going to be scrutinizing my CTM again. What did I miss?
I have a question for you, so just to know, do you think the dual CT can help more?
You mean dual
Dual energy.
Dual energy, I don't have any experience with it. I wouldn't be able to say.
And now, Cousin.
Just for dual energy, just what you know is like when you have a photon counting CT scanner, you can do this spectral imaging as well. This is the same information you would get out of dual energy. And we see like tiny veins a little bit better. But this, again, we sometimes don't know. We have the best machine, like a photon counting, for example, do a perfect scan, you don't see it because it's not open at that moment sometimes. So it's not, sometimes it's help, the contrast is a little bit better, but it's not the biggest advantage of it. But so, not really.
Thank you.
All of these things, the technology will continue to get better. But I think improving your technique as an operator is probably the most important step in the learning curve.
If I may, before Francesco, that maybe will close the question, I have a question also for Dr. Belgrado. Yes, please, just to know if do you think the headache chronic that can pass away after years, and so you don't understand if there was a headache or not, is just a adaptive phenomenon?
It's difficult because we had to know many more things. So I think there is a very comorbidity with the prior headaches that influence a lot. So what remains or what changes during time with the therapeutic approach or spontaneously is very difficult. So we have to base on our clinical skills first, and after, so we have to rely also on techniques, MRI and so on. But I'm just a clinician, so I think that we had to rely on our clinical skills before and trying to orientate our subsequent diagnostic workups.
Thank you to everybody. So we're under a pranzo. We have to eat, okay? We are late. We will see here at what time? Okay, 14:20. Grazie a tutti. Thank you, everybody. Follow the blonde lady.